Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream. Welcome to the show. Thank you so much for joining, and also want to welcome the viewers that are watching this on replay. I do these YouTube lives every Saturday evening, 6:30 p.m. US Eastern Standard Time, which is 3:30 p.m. Pacific time in the US on a Saturday. It is 10:30 a.m. my time on a Sunday, Sydney, Melbourne time. It is just 11:30 p.m. in the UK, Ireland. Once again, welcome to the show. So today we are answering questions, or I'm answering questions again for families in intensive care, and you can ask me anything, right? You can either type your questions into the chat pad, or you can join me live on the show here by clicking on the link that I'm just posting here in the chat pad. So if you want to join me live here and you want to ask your questions here live on the show, you're welcome to do so. Just posted a link here, a StreamYard link. You can join me live on the show here. You don't need to go on camera, but you can talk to me. Entirely up to you, or you can just post your questions into the chat pad. Before we go into today's questions, just very quickly, for those of you that are new, what makes me qualified to answer questions for families in intensive care? So I have been a critical care nurse for over 20 years. I've been working in 3 different countries for over 20 years. I've been working as a nurse unit manager for over 5 years in intensive care. I have also been consulting and advocating for families in intensive care for over 10 years now here at intensivecarehotline.com. Please look up our case studies, our testimonials, as well as some of our client interviews on our podcast. I can, without exaggeration, say that we have saved lives as part of our consulting and advocacy here. We have made sure that if there were end-of-life care situations, that families had a say, that it wasn't a quote-unquote one-size-fits-all that the hospitals and ICUs wanted to implement, right? Because that's what it often is, that ICUs want to implement a one-size-fits-all situation, a blueprint for that they have for many patients that stay there long-term to quote-unquote pull the plug, right? So, I understand the landscape, intensive care inside out, and I have developed with my team proven strategies so that families in intensive care get the outcomes that they want. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are sending intensive care nurses, pediatric intensive care nurses, and critical care nurses, including ED nurses, into the home for predominantly long-term ventilated adults and children with tracheostomies as a genuine alternative to a long-term stay in intensive care. We bring the intensive care into your home so that you and your family can improve their quality of life, and in some instances, quality of their end of life. We're also providing services for tracheostomy patients at home that are not ventilated. We provide services, intensive care services at home for BiPAP, CPAP ventilation, home TPN, IV antibiotics, palliative care, IV potassium infusions, IV magnesium infusion, porta cath management, central line management, PICC line management, Hickman's line management. With Intensive Care at Home, we are currently operating all around Australia and all major capital cities, and also rural and regional areas. And if you need intensive care at home in the US or in the UK, please contact us as well. We can help you there privately. So, without further ado, let's get into our first question today. And like I said, please type your questions into the chat pad or join me live on the show here. Let's read out the first question from Ryan, who says, hi, Patrick. My name is Ryan, and I'm reaching out regarding the current medical situation of my mother. My mom is 71, has been under the care of and I'm not going to mention the name of the hospital just to protect people's identity. My mom has been under the care of a cardiac ICU for over 3 months, recovering from complications following quadruple bypass surgery. Notably, a dislodged PEG feeding tube resulted in the development of necrotizing flesh bacteria pathogens. The medical team now deems her fit for transfer to a long-term acute care rehab facility. Her insurance coverage includes Blue Cross Blue Shield, PPO, and Medicare Medicaid. After thorough research and coming across informative videos by Patrik Hutzel, I have reservations about whether the proposed rehab facility is the most suitable next step for my mother's recovery. I kindly request your assistance in discussing alternative options and determining the most beneficial course of action for my mom's continued care. Thank you so much, Ryan, for writing in and sharing your mom's situation. Now, to give you the short answer, do not let her go to a rehab facility or LTAC. Now, I will, for full disclosure, I do know Ryan's mom's case in way more detail than I let on from this email, because we have worked with Ryan. So I do know his mom's care in very much detail, because Ryan was a client. And basically what we advised Ryan at the time was, to simply let the hospital know that he expects them to continue treatment for his mom in ICU, and that is exactly what they did. Right. Having said that, this is a really good case here to illustrate that, if you take responsibility and you get a second opinion, and you're not taking no for an answer, and you're doing some research, you will see a better outcome. So let me break this down in detail. When Ryan first reached out to us, he, shared the situation with me as it is. My first response was, well, why does she have a PEG? And I said, at this stage, when they recommended a PEG, he didn't know that she shouldn't have had a PEG. Obviously the PEG got dislodged, resulting in the development of necrotizing flash bacteria pathogens. That is terrible. And that's clearly medical negligence. And, for those of you who have watched my videos before, you would have heard me saying, do not give consent to a PEG tube. The only indication for a PEG tube is for someone who has, for example, high spinal injury, can't eat or drink, has motor neuron disease, has cerebral palsy, has spinal muscular atrophy, or has shown beyond the shadow of a doubt they can't be weaned off the ventilator and will be ventilator dependent for the rest of their life. That is not the case in Ryan's situation, or in Ryan's mom's situation. She has shown over time to have time off the ventilator. She absolutely needed no PEG. What this means, especially for our US audience, if you have a loved one in intensive care who can't be weaned off the ventilator and the breathing tube, and the ICU is suggesting or potentially pushing for a tracheostomy, they're often also pushing for a PEG tube, right? Now, my advice is do not give consent to a PEG tube and get a second opinion from us whether your loved one needs a tracheostomy or not, right? You shouldn't just rush into it. You shouldn't just jump on it. The first question you should be asking is, has the intensive care team done everything beyond the shadow of a doubt to avoid the trach and remove the breathing tube and extubate your loved one? And the answer is often no, they haven't. That's why the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. Right? So do not give consent to a PEG tube unless, ventilation and tracheostomy are irrevocable, which is not the case in Ryan's mom's situation, because when Ryan first reached out, she already had time off the ventilator. She could already pass spontaneous breathing trials. Now, again, especially for our US clients or for our US audience, when your loved one is getting a tracheostomy and a PEG, pretty much all LTACs will take your loved one, right? And they say, yep, we'll have a bed tomorrow, and off you go. Now, that's a disaster area waiting to happen. Have a look online for the LTAC reviews, see what people say, and tell me what you think. So, next, how can an LTAC deal, for example, with the necrotizing flesh bacteria pathogens that potentially need hyperbaric therapy? It's not available in an LTAC. You don't even have an ICU nurse in an LTAC, let alone an ICU doctor, right? So yes, the medical team might deem her fit for a transfer to LTAC or rehab. But your mom is nowhere near fit, right, to go to LTAC or rehab. Okay, so here's what's next. Then the hospital told Ryan that his mom no longer has entitlements for ICU, and the health insurance told the hospital she needs to go. So here's what happened. I advised Ryan, you need to speak to the health insurance, and so he did. And it turns out that his mom hadn't run out of entitlements. Okay, so then we advised Ryan to make a complaint to hospital executive that basically the hospital is lying to him, right? Lying to his mom, lying to his family, right? So turns out that after they made a complaint, his mom's ended up staying in ICU, of course, right? So again, everything changes if you take full responsibility. That's when everything is changing. Don't blame other people. Don't blame other people, right? You need to take responsibility. Only you will be able to make a difference. But believe that you can make a difference, right? If you don't believe you can make a difference, well, you already lost. You've already lost, right? One way to approach any situation in life, for that matter, is to take full responsibility for everything that happens to you, happens with you. Take full responsibility, because that's also the best approach to turn situations around, because then you're in charge. No one else is in charge, right? You are in charge. Take full responsibility. So this is another prime example when when you ask the right questions, you turn situations around very quickly, right? We have so many families inquire to us, and I can hear in their voice and sometimes in their email, they feel defeated. Well, if you feel defeated, you've already lost. You've already lost. Unfortunately, you will need to pick a fight sometimes. Unfortunately, you have to kick a stink. And unfortunately, I wish it was different, but it's not. You need to be persistent, and you need to be resilient as well. Bear in mind, when you challenge them, you are in the 1% bracket of families of critically ill patients in intensive care. There's only, I believe, only 1% of families in intensive care who ask, who question, who challenge, who get the outcomes that they need and deserve for their loved ones. But it only happens when you take responsibility. So stop blaming other people. There's no one to blame but yourself, and take responsibility. I know that sounds harsh, but that's also the reality. Just take matters in your own hands. That's all that matters. So, and then Ryan's mom was making progress because she was actually on the right track. Right? She was on the right track. And she is still on the right track because she's in the right environment. Again, this is very US specific. When someone goes from intensive care to LTAC, it's like LTAC is not even the better version of a nursing home, marginally better. Imagine someone on a ventilator with a tracheostomy on life support is going to an LTAC. It's a disaster waiting to happen, right? So I hope that helps and answers your question. It also encourages you to ask the right questions and keep the pressure on, because that's the only thing that will change when things change. You have to take responsibility. You have to get a second opinion, and you will need to take charge. That's the only time when things will change. Okay, let's move on to the next question. And if you have any questions, please type them into the chat pad or join me live here on the show. There's the StreamYard link that I put in the chat pad. You can join me here. In the meantime, I will move on to the next question. And the next question is from Mariah, who says, "Hi, Patrik. The ICU team asked me to move my father to an LTAC with an ICU because we are only day 6 of intubation and he's making progress in his weaning off the ventilator." Wow, that's a great question. And okay, the question here is, why would they want to move your dad to an LTAC with an ICU after only 6 days? Now, you haven't shared with me what condition your dad is having. However, if it's only day 6 of intubation, well, the primary goal here is to wean your dad off the ventilator and the breathing tube and extubate him. That's the medical term for removal of the breathing tube, and avoid the trach. And then there's no need for him to go to an LTAC. It almost sounds to me that they don't want to do the work to get your dad off the ventilator and the breathing tube, and they want to send him to an LTAC straight away. Like I say, it's almost like they're trying to have a one-size-fits-all approach, right? Well, the one-size-fits-all approach, if there should be any, is to avoid a trach, to extubate patients and move them onto a hospital floor or hospital ward and get them back to normality as quickly as possible. That should be the only goal they should be having. It's almost like they're making an excuse already. Well, we can't be extubating your dad. We can't avoid the trach. Very unlikely that they would know after 6 days. Very unlikely, from my extensive experience. This is once again where I'm saying the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. But I'm very glad, Mariah, that you have reached out and you are asking the right questions, especially if he's making progress. Why would he go to another place? So picture this. Picture this. Your dad is in ICU and he's on a ventilator, he's on life support. He's probably as vulnerable as he's ever been in his whole life. Probably. Now, sending him to another facility in a state where he's so vulnerable is just sheer madness. What a critically ill patient needs is a team around him that gets to know him, that wants to improve his situation. Now, if they want to send him to an LTAC after only 6 days, they've already given up on him. and they're already aiming for out of sight, out of mind. They're already aiming to maximize their revenue and profits rather than looking at what is best for your dad. Right? Again, picture this. Your dad is in ICU day 6. He's on life support. Very, very vulnerable. Almost like, you know, tongue in cheek when I'm saying this, flirting with death, you know, and now they want to send him somewhere else. That is sheer madness. Now, I tell you what I've seen. So patients going from ICU to LTAC, and then within 24 hours, they bounce back into ICU. And then they're bouncing back into a different ICU because the discharging ICU no longer has a bed available. And then they'd be looked after by 3 different teams within 48 to 72 hours for someone that's vulnerable, extremely vulnerable. That is madness. And it's negligent. And it's negligent. Right? And we here, you know, we need to challenge that madness. The system needs to be improved. The system is failing their people. Right? I know the system is failing your dad, your mom, your spouse, your child, whoever it is. Right? That's why you're here. But we can't stay silent about it. You know, we need to keep improving things. We need to raise awareness that the system is screwed. So, Mariah, I hope that helps. But similar to Ryan before, you know, make some noise, kick a stink, remind them of your rights, and, you know, reach out to us again so that we can walk you through it step by step what needs to happen to avoid the trach and get your dad extubated. That's what needs to happen. You don't need to spend time to find an LTAC. You need to spend time on holding them accountable and moving your dad towards extubation and the removal of the breathing tube. That's what you need to do here. Okay, let's move along to the next question. And if you have any questions, please type them into the chat pad or join me live on the show here by clicking on the StreamYard link. You can talk to me directly. You don't need to go on camera. Up to you how you want to talk to me. Okay, let's move along to the next question or comment. So, the next comment that I had from to one of my YouTube videos was from Helene, who makes comments quite frequently, and that's good. And she says, patterns for my mom from hospital to an LTAC was no more than medical human trafficking, drug trafficking, and misrepresentation, fraud, false claims act, etc. Medical exploitation and crimes, personal injuries, etc. Now I know that Helene had a very traumatic experience with her mum being moved from ICU to LTAC. She can probably vouch for everything that I'm saying about LTAC, and Helene has also joined me here live on this call to share her experience. So thank you, Helene, for continuing to highlight the system failures and for contributing to our cause here. Oh, thanks, Helene, you're here. Thank you for your contribution and for continuing to highlight the system failure, because that's what it is. Okay, let's continue with other questions from other viewers. From Jeanette, who says, adding to my husband's death, I want to know if I can see the video EEG when he was on BiPAP and aspirated bile from stomach content. I want to see if this is something that could have been prevented. My husband has right-sided weakness from his stroke and unable to use, and the headgear from BiPAP machine he probably could not remove. I feel this was medical negligence. I am so sorry, Jeanette, to hear what has happened here. Let me read this again so that everyone can understand what's happened here, and then I will explain. So Jeanette writes, adding to my husband's death, I want to know if I can see the video EEG when he was on a BiPAP machine and aspirated bile from stomach content. I want to see if this is something that could have been prevented. My husband has right-sided weakness from a stroke and is unable to use his right side. And the headgear from the BiPAP machine he probably couldn't remove. I feel this was medical negligence. Okay, so that makes sense. So I can tell you what probably happened here. So when someone is on BiPAP, and especially if they can't remove the mask themselves, and especially if they're being fed with a nasogastric tube or with a PEG tube, or potentially even fed orally, the aspiration risk is real and it's pretty high, right? Once again, especially with a stroke, right? Your husband might have also had difficulties to swallow because of the stroke. So he would have been at an increased aspiration risk straight away. Now, chances are that he vomited, and like you said, he could not remove the BiPAP mask. Chances are, because he could not remove the BiPAP mask and the BiPAP mask was pushing air into his lungs, that he aspirated bile into his stomach. The chances are real that this is what's happened. Okay, so what you need to find out is, was he fed? Right? If he was fed and he had nutrition, that in and of itself is something dangerous. But even if he vomited, for someone with BiPAP, they need a one-to-one critical care nurse. So you've heard me talk about LTAC in the last, over the last 20 minutes or so, and the risks. So imagine if someone with BiPAP who doesn't have a trach needs a one-to-one nurse, critical care nurse. Well, it's even more dangerous if someone is having a trach. Well, both is risky, right? But in order to maintain standards and protect human life, there needs to be a one-to-one critical care nurse. Full stop, right? And this is evidenced in the mechanical home ventilation guidelines that you can find at our website, intensivecareathome.com, where in a home care environment, there needs to be a one-to-one critical care nurse for ventilation, tracheostomy, for tracheostomy without ventilation, BiPAP, CPAP ventilation. There needs to be an ICU nurse, critical care nurse with a minimum of 2 years critical care nursing experience, 24 hours a day. It doesn't look to me like your husband had that in an ICU, Jeanette. So therefore, it was definitely medical negligence, because at the time when he vomited, the critical care nurse, if he had one-to-one, should have stopped the BiPAP, pulled out the suction machine, pulled the mask off, and managed this and avoid aspiration. So therefore, I argue there is medical negligence. So here's another question, Jeanette. Why did your husband not have a tracheostomy if he had a stroke? There are unfortunately many stroke patients need a tracheostomy because they are at risk of aspiration. They can't swallow. Maybe that isn't what was necessary. I don't know. I'm just putting out the question here that you should probably be researching. Why did he not have a tracheostomy? Right? He could have had the BiPAP with a tracheostomy. Now, here is another question. Would he have needed TPN, which is IV intravenous nutrition? Because that'll bypass the stomach, and that'll eliminate the risk of aspiration, right? So I hope that helps. Jeanette, to explain why it was probably medical negligence. But it would if he had feeds, nasogastric tube feeds, oral feeds, or PEG tube feeds, whilst on the BiPAP, that would also be negligent. It also depends how much pressure he was getting through the BiPAP. Was it a lot of pressure? You know, what was the BiPAP set at? Was it 5 and 10, or was it 7 and 20, or 12 and 20? You know, there's different settings for a BiPAP. So there are a lot of questions that you need to have answered here. Okay, so Helen, you have made a comment here and you are saying LTAC wayward physicians discontinued water to saline into her PEG tube. Water to saline. This was concealed from me. Look, thank you for sharing that. I believe that a lot of things are concealed to families in intensive care. Unless families know what questions to ask, unless families get access to medical records, unless families know what to ask for and what to look for, a lot of things are concealed, unfortunately. No surprises there, unfortunately. So then let's move on to the next question, and please keep sending your questions here in the chat button or join me here live on the show. Now, I have an email here from Jerry who says, "Hi Patrik, my wife is in ICU and has lung cancer and is having trouble getting off a ventilator with a tracheostomy. They will not let our young kids see her. Help." From Jerry. Wow, that is unbelievable. That is unbelievable, Jerry. Well, if your wife is having a tracheostomy and she's having lung cancer, depending on what stage lung cancer it is, she might have difficulties getting off the ventilator, right? Let's not beat around the bush, right? It really depends on, is it stage 1, stage 2, stage 3, stage 4? Can they operate on it? Can they do radiotherapy? Can they do chemotherapy, right? My question is, what's the oncologist saying in regards to that? But if the cancer is spreading in the lungs, it'll be very difficult for her to get off the ventilator. Very difficult. Now, they will not let our young kids see her. It's shocking to me to hear that, Jerry, and I feel very sorry for you and for your family and for your kids in particular, but also for your wife. Well, the only thing that I will say to that is make a complaint, make some noise, don't be intimidated. It's very inappropriate for the hospital to say you can't see your kids can't see your wife, right? Make a complaint, write a letter to the hospital board, hospital executive, and consider, in a situation like that, consider intensive care at home instead. Okay, consider intensive care at home for your wife to go home. She can have weaning at home if it works, but even if it doesn't work, she can have end of life care and palliative care at home, right? If that's where it's going. So, but make some noise here and look for solutions. Okay, let's look at the next email that's come in from Pamela. Pamela says, "Hi Patrik, my husband has been in hospital for over 4 months and will be coming home but needs TPN feeding and has a tracheostomy. I want to let people know that kidney failure can be reversed in the hospital, as my husband had no kidney function and has dialysis and diuretics together for a couple of weeks and lots of prayers, and now his kidneys are working perfect. He does have problems from the drug-induced coma they put him in and has 3 internal bleedings and pneumonia and lung infections. We are hoping to get Medicaid nurses to help with his care, but not sure how that will work, from Pamela. Well, Pamela, thank you so much for your email and for your comments. Of course, I mean, I have been saying this for many years on my videos here and my blog posts, that kidney failure in ICU is often temporary. And the reason it's temporary is simply that, you know, when patients come into ICU, they often become hypotensive, i.e. their blood pressure is low, or they have an infection, or they have sepsis, and then the kidneys take a hit, right? They have low blood perfusion, and because they have low blood perfusion, right, they take a hit and they stop working properly. And sometimes Lasix or other diuretics will help, and sometimes it won't help. Sometimes patients need to go on dialysis or hemofiltration. That gives the kidneys time to recover, and then they often come back in full swings, which is exactly what's happening here. Now, my concern here is, Pamela, that it's great that your husband is going home, but with TPN feeding and a tracheostomy and with Medicaid nurses, he will probably either die or he will go back to hospital in no time. So what you need here is you need intensive care at home for your husband. I've made some videos recently about where a client wanted to take their family member home in a similar situation, and they wanted to manage it themselves, and they bounced back within less than 24 hours back into ICU, just as we predicted at the time, right? And if you're getting Medicaid nurses with low skilled, that you might as well go into LTAC. But LTAC couldn't manage TPN, and neither can Medicaid nurses, right? So you need to set up, you know, the highest level of care for home care, which is intensive care at home, making sure that your husband gets best care and treatment, and also gets evidence-based care and treatment, right? So that he can stay home predictably, because I fear he won't be staying home predictably if you don't have 24-hour intensive care nurses like we do with intensive care at home, right? And also, it sounds to me like he has other problems and complications, such as internal bleedings, pneumonia, and lung infections, right? We can manage that with intensive care at home. I argue with intensive care at home, we're looking after the highest acuity clients in the community, right? There's no other service in Australia or in the US that can look after a higher level of acuity than intensive care at home. So go and check out intensivecareathome.com and contact us there so we can set up home care properly, so your husband is not at risk of dying, or your husband is not at risk of going back to ICU either because the tracheostomy dislodges and nobody knows how to manage his airway, or he gets a sepsis from a line infection for the TPN. You need also a critical care nurse there to manage that. Okay, we've had clients die in the community with intensive care at home because the funding bodies were only funding night shift for a critical care nurse, right? For clients with ventilation, tracheostomy, one of the clients was two of the clients only, quote unquote, only had a tracheostomy, but were not ventilated, but they died when we were not there, just as we predicted, because of unsafe practices from insurance and funding bodies, right? If a critical care nurse isn't funded 24 hours a day for situations like your husband's situation, Pamela, he's at risk of dying, right? And we have the evidence to back up what we're saying, that, you know, with TPN, tracheostomy, ventilation at home, if there's no critical care nurse, clients die. It's similar to an ICU. If there's no critical care nurse in an ICU when patients are ventilated, TPN, etc., they're at risk of dying, right? It's not any different at home. So a really strong word of warning here, Pamela. You will need intensive care at home to make this safe and keep your husband home predictably, okay? And safely, more importantly. Don't budge and don't negotiate on quality. Never negotiate on quality. Never budge on quality, right? Now, just got to give me 1 second. I will be right back. I'm going to the next question now, but just quickly need to change my position. So let's move on to the next question, who is coming from Lisa. Lisa says, "Hi Patrik, the ICU my husband is in doesn't provide advanced treatments. They give you constant negative news. Can you help?" Okay, that's great. So you must have done some research, and you would have seen that the ICU is giving you limited options, right? And that's good. You are doing your research and you're making progress. And instead of offering you advanced treatment, they are giving you negative news. So they're trying to create a narrative or a negative narrative that gets them what they want. Well, what do they want? They want to empty their ICU beds as quickly as possible to get the next patient in. They don't want to deal with what is their worst case scenario. So what is an ICU's worst case scenario? Their worst case scenario is to treat a patient, a critically ill patient, long term with an uncertain outcome. And by them potentially withholding advanced treatment, right, and telling you negative news all the times, they're trying to minimize their risk and trying to avoid their worst case scenario, clearly. So, what to do? Well, what you do in a situation like that is, first off, you tell them what to do, you tell them what you expect, right? We can make the clinical argument for you what advanced treatments need to be available for your husband, right? And we look at medical records, we can confirm with you what other treatment options are available. And that will then challenge the intensive care teams to stop giving you the negative news, because they know that you are talking to someone who understands intensive care inside out, right? And then they need to provide you with advanced treatments, right? And we can help you with the complaints process, with the advocacy process. Like I said, I'm not exaggerating here when I'm saying we have saved lives, many lives. As a matter of fact, you can look at our testimonial section, but you also need to take full responsibility, right? You need to take full responsibility, Okay, I hope that helps, Lisa. Now, Helene, you're saying, Patrik, did I hear you correctly that a PEG tube can get infected, dislodged? Yeah, of course. Of course. Anything can get dislodged. It's just a PEG tube is a foreign body in someone's stomach. And of course, it can get dislodged. A nasogastric tube can get dislodged. A tracheostomy can get dislodged. A breathing tube can get dislodged. Of course. Unfortunately, that is the case. Any foreign body, central line, peak line, all can get dislodged, right? So, any foreign body that is in someone's body can get dislodged, So there's always a risk for that. Okay, so Munessa sends another question, and Munessa says, "Hi Patrik, what is cerebrate posture? That's the condition the doctor said my dad has." Now, cerebrate posture is an abnormal body posture that involves the arms and legs behind held straight out, the toes being pointed downward, and the head and neck being arched backwards. The muscles are tightened and held rigidly. This type of posturing usually means there has been severe damage to the brain. So, Munessa, can you tell me more about your dad's situation? Does he have brain injury? What got your dad into this situation? If you can tell me more, that would be great, because it sounds to me like he might have brain injury. Okay, while I'm waiting for your reply, Munessa, let's just look at the other emails and comments that came in. So, another question comes from Rohit, who says, "Hi Patrick, my husband met with an accident recently and has undergone brain surgery as the brain is immersed in blood and also had a couple of clots. It's been almost 13 days. He's not conscious. He's moving his hands and legs. Can you please answer to this? When can we expect him back to normal?" Right, Rohit, this might take some time, right? And this could take days, weeks, months, and sometimes it takes years, right? 13 days not being conscious after brain surgery and an accident is probably not a long time. I know it feels like an eternity to you, but it's not a long time. Okay, so you've got to be patient here. You've got to be very patient, right? I'll come back to your question, Rod. I just want to carry on here with Munessa, who says, "My dad had a cardiac arrest." Okay, so if he had a cardiac arrest, how long was the quote unquote downtime? So the question is, how long did his heart stop? How long did they do CPR on him, cardiopulmonary resuscitation? How long did it take them to get a pulse back, right? Have they done a CT scan of the brain? Have they done an MRI scan of the brain? Have they done an EEG of the brain? The doctor says he has a hypoxic brain injury. That's what Munessa says. Yes, of course. So, okay. So, few more questions here, Munessa. So, have they done a CT scan of the brain? Have they done an MRI scan of the brain? Have they done an EEG? How many days ago did he have the cardiac arrest? And how long was the downtime, i.e., how long did they do CPR on him? And how long did it take them to get a pulse back? If you could answer those questions, that would be great, Munessa, because then I can, point you further in the right direction of what to do next. He also might have seizures with the cerebrate posture, right? So coming back to Rohit, who says, after 13 days in ICU, he's not conscious. Yeah, you will need to give this time. Have they mobilized your husband? Is he still on sedation? Right? What does MRI scan of the brain show? CT scan of the brain? EEG, what does it show? Right? So can you expect him back to normal and in what time frame? Very hard to say. Very hard to say, because I don't have enough information to say how long it'll take for him to get back to normal. Whether he will get ever back to normal, but can he improve? And if he improves, right, is that a quality of life that's acceptable for you and your family? Right? So really important questions here. CT scan of the brain, MRI scan of the brain, EEG, is he still sedated? Is he having seizures? Can they mobilize him? Does he have any other fractures because he was in an accident? What else is stopping him potentially from waking up? What medications is he on? Especially opiates and sedatives would be really, really valuable. Your answers here would be really valuable to help me answer your questions. And Munessa, you are saying they have done all the tests. He's not having any seizures. The cardiac arrest happened 6 days ago. Okay. Not a long time, Munessa. Just to put things into perspective here, not a long time. Just because he hasn't shown any signs of improvement for 6 days, that's not a long time. Give it at least 6 weeks. Give it 60 days at least. And then he doesn't have any other injuries. Okay. What does the MRI scan show? What does the CT scan of the brain show? What does the EEG show? How long did they do CPR on him? So those are really questions that you need to consider. Okay. Helene, you are saying LTAC nurses are Coca-Cola and warm water to declog mom's PEG tube because water flushes were lowered. I believe that is what burst the PEG tube balloon. I'm not sure about that, Helene. I have unclogged PEG tubes with Coca-Cola. I have successfully. I know it's no longer recommended. I get that. It is no longer recommended, but I can say that, you know, I have declogged PEG tubes with Coca-Cola with much success. But I think it's banned now, and you might actually be right, but it used to be best practice. It used to be best practice, and I can tell you it used to work. Right. Okay. So let's move on to the next question. That is from next question is from Boyd, who says, "Hi Patrick, my brother is in a coma in the last, or has been in a coma in the last 5 months after brain hemorrhage. Could you please help? How many times, how long does it take to recover from a coma? The body movements are actually decreasing after many seizure attacks, and he keeps having them. Can my brother improve?" Wow. That's a great question, and I'm very sorry to hear about your brother. If he's having seizures, the first thing they need to do is they need to control the seizures, right? And one way to control the seizures is simply by optimizing his anti-seizure medications, because if he keeps having those seizures and you know something's not working, he needs to be seen by a neurologist as quickly as possible, right? And someone needs to look at his anti-seizure medications, right? Now, I don't know, you know, what it looks like, what your brother's day-to-day life looks like. It doesn't look like he's doing all that well at the moment. But the first thing that he needs to do, that someone needs to do, ideally a neurologist, is to review his anti-seizure medication. Okay, so, and then only then can you see what else can be done. But he can't be having seizures every day. You know, he can't be having seizures every day. You also haven't shared with me where your brother is. You know, you're telling me it happened 5 months ago. Is he still in hospital? Is he at home? If he is at home with unmanaged seizures, he probably needs intensive care at home. He probably needs intensive care nurses at home 24 hours a day. Again, go and check out intensivecarehome.com. Okay, let's move along. Munesa says, "I'm not sure about the results of the tests until tomorrow when we speak to the neurologist, but they didn't get a pulse for 27 minutes. What kind of question should I ask the doctor?" Right. Wow. Okay. You definitely should be asking for the tests, the test results. If they didn't get a pulse for 27 minutes, chances are he may not fully recover, right? So what you should be asking is get the test results, MRI scan of the brain, CT scan of the brain, EEG result, right? Does he have seizures? He might have with cerebrate posture, he might have seizures, right? Is he still sedated? Because if he's not waking up, it could be as simple as that he is still on sedatives, right? And he might be on sedatives to avoid seizures, right? Because that could also keep sedating him, right? And some sedatives, some like Versed or midazolam, which is known as a benzodiazepine, is also an anti-seizure medication. So they might kill two birds with one stone. But the question is, what if they take the medications are okay? Medications are okay, you're saying he's not sedated. Okay. Is he still on pain medications such as morphine or fentanyl? Because that also has sedative effects. And is he having anti-seizure medications because they are also having a sedative effect? Right. So I know this is pretty daunting, Munessa, situation like that. I would get the full list of medications. I would also ask and talk to a cardiologist and find out what his heart is doing. Because if his heart is buggered, right, is he still on inotropes or vasopressors? Right, so it's not on opiates, not on fentanyl or morphine. Okay. Right. Okay. So speak to the neurologist. But I can tell you, if he's off sedation, he's not waking up, he's got the cerebral posture, ask them if he's got seizures, ask them if he's got anti-seizure medications, ask them about the prognosis. It might be negative, but then you have to also keep in mind, 6 days in a situation like this is not a long time. Don't rush into any decisions, and don't make decisions today that you will regret in 12 months' time. That is my advice. Do not make decisions today that you will regret in 12 months' time. And that's where I want to leave everyone today. I am going to wrap this up in a minute. We usually always go for about an hour. Now, if you want to continue the conversation, you can reach me directly on one of the numbers on the top of our website at intensivecarehotline.com. Or you can send an email to support@intensivecarehotline.com. I do offer one-on-one consulting and advocacy over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. I do talk to doctors and nurses directly. I ask all the questions that must be asked, but you haven't even considered asking, right? And I get real results by talking to doctors and nurses directly because I hold them accountable, right? We also have a membership for families of critically ill patients in intensive care at intensivecarehotline.com. If you click on the membership link there, or if you go to intensivecaresupport.org directly, there we answer all questions intensive care related. Like I said, I also offer one-on-one consulting. I have worked in intensive care for over 20 years in 3 different countries. I have worked as a nurse manager for over 5 years, and I've been consulting and advocating for the last 10 years here at intensivecarehotline.com, getting real results for our clients. Have a look at our testimonial section and our interviews we've done with clients. Now, I also represent you in family meetings with intensive care teams so that you don't get walked all over, and I'll make sure that you are, if you are going into a family meeting, that you get results. So, and just quickly, Cindy, you're asking, where can you read stories of people who wake up and what they remember? Go to icusteps.org. That is icusteps.org. That's a blog for ICU survivors. That is, once again, icusteps.org. We also offer medical record reviews in real time if you want a second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. If you need intensive care at home for your loved one in ICU, long-term, ventilation, tracheostomy, no ventilation, BiPAP, CPAP, home TPN, home IV potassium infusions, PEEK line, central line, Hickman's line, and port management at home. We offer that with Intensive Care at Home. For more information, go to intensivecareathome.com. With Intensive Care at Home, we are currently operating all around Australia. We also offer level 2 and level 3 NDI support coordination. If you need us for Intensive Care at Home in the US or in the UK, we can help you there privately. Please reach out to us. And if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button of the video, click the notification bell, share the video with your friends and families, and comment below what you want to see next or what questions and insights you have. Thanks for watching. This is Patrik Hutzel from intensivecarehotline.com and intensivecareathome.com. And I will talk to you in a few days. Take care for now.